Are you feeling nervous about starting your next post in obstetrics and gynecology? I felt the exact same way, as I didn't have much experience in obstetrics and gynecology in medical school. In this video, I'll share with you my experience of obstetrics and gynecology from a GP trainee perspective, and I'll share with you my top insights. If you're new to the community, hi, my name is Dr. Erwin. I have high performance, great habits to lead a happy and successful life. You'll find on this channel videos about well-being, high performance, and my experience as a doctor. Please consider subscribing to this channel for new videos every Thursday. A rotation in obs and gynae may be daunting for many GP trainees, since the last time you probably had experience of obs and gynae was when you were a medical student. Let me reassure you that you won't be expected to decide on delivery method or manage difficult cases on your own. However, you will be expected to take a history from a pregnant woman, examine them and manage them safely, and seek senior help as required. I found my rotation in obstetrics and gynecology very intense, and I learned a lot from the job. There were some days, however, that I felt emotionally drained with the demand and the pressure of the job. It's useful to know how the Women's and Children Department is organized. You have the labor ward, where primarily pregnant women who are actively in labor are managed there. You also have women who are planned for induction of labor who are managed in labor ward. And labor ward also has a theater where there's patients who come in for elective or emergency C-section or other procedures done there. There's a team of midwife, obstetrician, anesthetist, and also pediatrician who can come when there is an emergency C-section. You also have the midwifery-led unit, which is a unit led by midwife, and pregnant women who go there, they don't have risk factors or any medical problems, so their care is under the midwife and they don't require input from the obstetrician, except when there are any complications. Some of the women are then transferred to labor ward who may need further escalation of their care. The next ward is antenatal ward. This is an inpatient ward for pregnant women who may have been admitted for high blood pressure in pregnancy, preeclampsia, hyperemesis gravidarum. After delivery, if women still need inpatient care, then they're transferred to postnatal ward, where they receive the care there. You may also be called at the maternity daycare unit, which is a unit for pregnant women above 16 weeks who have any complications or any problem during the pregnancy. Then they can call there and seek advice. Some of them will have to come and they have their blood test done, blood pressure monitored, and CTG monitored. If we look at the gynecology aspect of the job, there's early pregnancy assessment unit. It is for women early in their pregnancies, and the unit is led by a specialist nurse or midwife, and it works with the gynecology assessment unit. So there is a sonographer who is there, a senior doctor, and a specialist nurse or midwife. Common cases that will be seen in early pregnancy assessment unit are miscarriages and pregnancy of unknown location. In the gynecology assessment unit, you'll have patients referred by GP, by A&E with pelvic pain, PV bleeding. Some of them will have prolapse. These patients are assessed by the doctor there, and they have a history taken, examination, and some of them will need to be admitted. Then you have the gynecology wards for patients who are admitted with early pregnancy bleeding, ovarian cysts, ectopic pregnancy. And you also have gynecology ward for patients who have gynecology cancer. Common gynecology cases you will see are women presenting with pelvic pain, women presenting with PV bleeding. So it's very important that you take a good detailed gynecology history. So this is your generic medical history, and then make sure that you take a detailed history of the menstrual cycle, the first day of the last menstrual cycle. What is the cycle like? How regular is it? Is it regular, irregular? Do they have a lot of bleeding? So menorrhagia, you can quantify it by asking how many pads they have to use, whether they have any flooding, whether there have been some irregularity in their cycle. and then ask them about red flags. Things like whether they have any bleeding in between their period. Any bleeding after menopause is considered as cancer until proven otherwise, post-menopausal bleeding. So things like that you need to be aware of. You need to ask questions about any pain during intercourse, dyspareunia, or any postcoital bleeding. Things like that you need to elicit in your history. And then ask about obstetric history, whether they've had any pregnancies before, any complications, because it's important to know about their obstetric history. Make sure you familiarize yourself with gravida and para. Gravida is defined as a number of times that a woman has been pregnant. Parity is defined as a number of times that a woman has given birth to a fetus with a gestational age of 24 weeks or more, regardless whether the child was born or alive or was stillborn. For example, if a woman is described as gravida 2 para 2, sometimes written as G2P2, it means that she has 2 pregnancies and 2 deliveries after 24 weeks. A nulliparous woman has not given birth previously. A prima gravida is in her first pregnancy. And then you need to take a sexual history, especially if you're suspecting any pelvic inflammatory disease. You need to know whether they've had the cervical smear done and whether they're using any contraception, and then your basic history that you would take for any patient. After the history, then you proceed on to examination. So with examination, it's very important that you gain consent from the patient. Make sure that you explain clearly what you're examining and the reason why you need to do the examination. Always ask the patient whether they need to empty the bladder, especially if you're going to do a bimanual examination. It's important that you have a female chaperone present when you gain consent and examine the patient, and that you document it in the note. It's good practice to examine the abdomen before doing a bimanual examination. The 2 examinations that you will do are speculum and bimanual examination if necessary. So make sure that you read on speculum examination and familiarize yourself with the use of the speculum. And then with the bimanual examination, make sure that you know exactly what you're feeling for and what are the things that you need to look out for. When it comes to taking vaginal swab, you'll have to take 3 swabs. So there's the triple swab, the high vaginal swab, and the cervical swab, and then the chlamydia one. It's important that you give privacy to the woman before the examination to undress, and then after the examination to redress. And then once you're redressed, then you can explain your finding to the woman about your examination. As a GP trainee, it's very important that you make the most of your obstetric and gynecology post. So there are clinics that you could attend. Look at what are the clinics available that you could attend and plan this in advance. So there's gynecology outpatient clinic, which is very useful because you see the cases that GP refer to outpatient gynecology, and you see how the gynecologists manage these patients. And then there is fertility clinic that you could attend just to see how the procedure and what are the tests that are done. There's also genitourinary medicine clinic, gum clinic that you could attend just to get experience as to how there is contact tracing done, how sexual history are taken, and what are the examination and management. So before you start your placement in obstetric and gynecology, make sure that you familiarize yourself with local guidelines. So make sure that you read on the management of pregnant women under 12 weeks who come in with pelvic pain or PV bleeding. If you have a referral from A&E, make sure that you ask them for urine pregnancy test, because pregnancy is one of the things that you need to consider. And especially if there's any woman presenting with pelvic pain and they're pregnant, ectopic pregnancy is something that you need to look out for. If the woman is pregnant and has pelvic pain, then ectopic pregnancy is one of the top differentials until proven otherwise. Suspected ruptured ectopic pregnancy is an emergency. You need to get your senior informed urgently, get the anesthetist, make sure that you secure IV access, take the basic bloods, and make sure that you include a group and safe. In terms of PDP, make sure that you arrange to sit in outpatient clinics, gynecology clinic, colposcopy clinic, genitourinary medicine clinic, and you'll also be able to complete your clinical and examination procedures and get these sign off. I hope you find this video valuable. Let me know in the comment section. If you want more videos like this, please like this video so that I know. And don't forget to subscribe to my channel for new video every Thursday. Take care everybody. Bye bye.